2.
We decided to, was at the public club side.
Nice warm room, dark Friday afternoon, post-lunch. But we have the wonderful Dr. Gene Shaffer, who's been a previous co-chairman of this meeting, who's a Temple alum, who's now up the road at Albert Einstein, who is going to be the session moderator for our afternoon, to kick off our afternoon, which will be challenges with ankle fracture management. We're very lucky to have a wonderful panel. Dr. DeLong has been on a panel this morning. We have Dr. Marcus Sciadini from Shock Trauma and Dr. Emmanuel Illical from Albert Einstein up the road. We appreciate Dr. Shaffer giving us a dynamic session this afternoon, and I'll hand over the reins to him.
We are going to use the ARS, the Audience Response System keypad, mostly for some questions about what you do when you're facing some of these. Our panelists will discuss that as well. There's 3 or 4 of them, but I think they'll be interesting to sort of see what what people are doing out there with these things, because there are, with ankles, maybe as much as anywhere in orthopedics, some choices and some different ways to do things that may be interesting to take a look at. So there we are. The challenges, I think Sakab was trying to just leave it nice and broad, so we're going to do that. We're going to hit a couple big areas in ankle fracture management. There are some disclosures in the program. And again, these will be case reviews. I did add a few slides on literature review. We can go through them quickly just to hit home some points. But to jump right in, our first case, this guy showed up to me to the office, 54, healthy. He had a twisting fall. I put the knee up there. I don't think he came with the knee x-ray. He did come with the helpful 2 arrow sign from radiology. He does have a posterior malfracture on that film. He was having pain attempting weight bearing. He did come into the office with crutches and then gave it away. I added the knee x-rays in the office. Dr. Illical, what do you see here?
Sure. So looking at the kind of 3 views given, I would see like a sort of like at least a minimally displaced posterior malfracture, best seen on that lateral. And I think I can sort of see that kind of flame sign on the AP. It's probably kind of Maisonneuve type injury because there's a proximal fibular fracture as well.
Dr. Sciadini, anything to add?
I mean, only that you have the middle image is sort of a almost over-rotated AP that doesn't appear to show any syndesmotic or medial joint space abnormalities, but it's not a great view. So I'd probably want a better view of that. And if it were normal, I wouldn't necessarily stress it.
So you don't routinely stress yours in the office?
If they're normal on the static presenting x-ray, I think recent data suggests that even if they're stress positive, they don't necessarily need fixation.
Dr. DeLong?
Yeah, I would echo that remark. I tested the medial side of this and an x-ray that looks normal in a normal mortise and AP view. I wouldn't stress either. I don't see a big sign. I can't exactly see how big that posterior fragment is. I'd probably, if I was worried about anything, I'd get a CAT scan. You know, is this a posterior malfracture or is this a pilon? Sort of 6.5 doesn't, you know, I sort of, I think I'm good with where it is, but this is a relatively young person, and I might want to look at this a little bit more.
Sure, and I thought this was a good one because it has a lot of thought process to it. I like to show this to the residents because it's a great pronation external rotation. He's got the fibula anterior superior to posterior inferior, which is the opposite of the SER, and it's the classic Log-Hansen description of that fracture pattern. I do like to stand these or best effort weight bearing in the office. I like to see where they end up if they're wide when they stand on it or try to. But really, it's a pretty well-reduced ankle. Do we think this is unstable? Dr. Sciadini.
I kind of doubt it, but you can also be fooled. I think I like the idea of the weight-bearing films because that can sort of be the thing that helps you catch one that you think is stable that isn't.
Dr.
Yeah,
Illical?
yeah, I agree. If they come to the office and they've been kind of walking on it sometimes, and you get x-rays and they've kind of done their own stress test, I agree with Dr. DeLong, like with these posterior malleolus fractures, in a young person, if I tend to be aggressive, I tend to get a CT scan just to better delineate how big and that fracture pattern is and whether there's like marginal impaction, et cetera.
This is a course about surgery, so we did do something for this. So we'll go to the audience response. The question is, would you fix the syndesmosis with a screw? Would you use a suture button device? Or would you have some other method of fixation? These are apparently 10-second audience response times. And we'll see what people think. What other might you think about, Dr. DeLong?
Other ways of fixing this?
Yeah, or is a screw good enough or a suture button enough? There's some discussion recently where if you see a posterior mal and you're worried about the syndesmosis, the best way to fix the syndesmosis is to fix the posterior mal.
Yep. The approach to plating this posteriorly provides great stability. It pulls everything in, and that's when a single device really makes this quite stable.
So who puts a screw in this? Dr. Illical?
So personally, I'd go with Dr. DeLong. I'd probably plate his posterior mal and then stress him intraoperatively, and if he wasn't unstable, then I would kind of leave it, because like as you said, there's literature now showing that if you fix posterior mal, keep the PITFL
It looks
intact.
like that, though. You gonna put a big
Yeah.
plate on the back of that?
So
I would. And not a big plate, I'd put a little mini frag plate.
So to jump ahead, this is what was done. And, the rationale here was keep it relatively straightforward. I thought that the medial lateral instability was his risk. He has that proximal injury. You have to imply the whole IOM all the way up to the fracture's unstable, and I would prefer that not displacing and small incision. I don't let him walk on it, but this is what I decided to do for him, and this is him at 6 months. So any tips on suture buttons? Anybody who likes them, hates them, anything you would not do in terms of this? Dr. DeLong?
no, that looks great. Suture buttons aren't my first choice because I grew up as a hardware man. We use them for syndesmotic repair from time to time. I think of hardware first, and this obviously worked.
Would one have been enough?
Pardon me?
Would one have been enough?
Uh-oh.
I gave the suture button company 2 devices. We paid for
Yeah.
2 here. They did not
Yeah.
give me a discount for the second one. It wasn't a buy one, get one.
The answer was that 2 did the trick, and 1 might not have. So now, in retrospect, I'd say 2 was a fine choice.
Any other? So part of the rationale I do for 2 is, and it was described, I did I think I saw Chris Kotsia present this once, but the incisure is round, and if you put 1 in, the suture button can only do compression. You squeeze between the 2. If you put a second in that's a little bit out of plane, I'll have a diagram later on, but you can get that bone into the curve and hold it there a little bit better, which was the intention. That may have been perhaps not so well done, because you can see on the lateral, the 1 button is pretty far in the back. And luckily, he did not have any problems with that, but I did have a patient, somebody else put a suture button in, and it irritated the neurovascular bundle. Probably the wire came through, and I ended up having to take it out. But these two held him in place. He healed and got back with this. So now we'll go to a different one. This is a little bit different animal, very different animal, I think. So a healthy 20-year-old lacrosse player and playing lacrosse comes in with these pictures. Dr. Sciadini, what do you see?
You've got a AP and lateral ankle. It looks like a unstable bimal, splinted in equinus. Not sure if there was a dislocation event associated with this and if they had to splint him in equinus to keep him reduced, or if that's just a poorly positioned foot and ankle in a splint. But I think by definition, in this age group, in this fracture pattern, this is an unstable pattern that deserves fixation of both the lateral and medial malleolus and intraoperative syndesmotic testing.
So, again, we're kind of on a syndesmosis mode here. Again, with this, and we're thinking hardware, both medial and lateral hardware. The question for the crowd is, screw for this one, do a suture button like the last case, or some other who does not have a posterior mal that we've identified. You can put that ARQ up. Any thoughts from the panel?
Yeah, like I think growing up, like my management of syndesmotic injuries in terms of the fixation choice has changed, even though I'm not, I'm only like 6 years out, but residency I was definitely all screws, and I've kind of gone more and more to suture buttons, and especially in kind of younger patients, and those fracture patterns where I think that the syndesmosis is probably unstable, but not grossly kind of like dislocated, just because it's, I think in the end, like the whole dynamic fixation probably does better in a younger patient. But
Yeah, and we're looking at nearly 60% of the audience using a screw for this, when you're obviously going to use a plate on the lateral side, but not everybody, and there's a lot of others here too. So a little bit better closed reduction, got him out of his equinus. Anything more about that fracture pattern or how it looks or anything, Dr. DeLong? Hard
Yeah.
to see with the splint.
Yeah, it's hard to see it through that. So this is a pattern that it looks to be very unstable, and the transverse nature of the medial malleolus makes you want to consider a cannulated screw there. That might be successful. In some cases, a tension band might work better if this piece looks small when you get there. I would plate.
I'm going to jump in. I echoed that. I think this is one of those medial mals that really can be a bother because it's tiny, and the obliquity is almost not even transverse. It's kind of oblique up into the joint, so it's hard to get that and hold it. And since it's my case, I'll tell you that it was. But yeah, that can be a tricky medial mal.
Yeah, I mean, that may be a tension band, or if it gets troublesome, you could even use a 1/3 tubular plate to try to provide stability there. The fibula, I would reduce and plate, and try to stabilize that as best I could. And then stress test it. This is a place where you could elect to use a suture button or a tightrope device, something like that, or go with a 3-cortical screw if instability was present.
And I hear you saying stress test it, and also said earlier. So this is a pretty classic Weber C. It starts, the fibula fracture starts above the syndesmosis, but you could restore stability with plate fixation of the fibula alone, perhaps not need syndesmotic fixation.
Possibly.
Yeah, and I think that's important to understand, is that if you get excellent bony stability of the fibula and the medial side, if the syndesmosis is not unstable, it does not does not need to be fixed. So these are proximal fibulas with comminution can be struggle sometime, and this young healthy guy, I did go for a thicker plate to try and hold him, and to bridge the comminution, I stayed out of all the bone, obviously, but ended up with a pretty low syndesmotic screw. Anybody have thoughts on the height of placement of your screw, good, bad, where you like it, where you don't? Dr. Illical?
Yeah, I kind of try to be like, at the level of the distal physeal scar. But obviously, like, depending on the fracture pattern and stuff, sometimes that's not possible, so sometimes I have to go a little bit higher, a little bit lower. I think the challenge is, like, placing that syndesmotic whatever fixation in the appropriate plane to keep the syndesmosis reduced. I think that's the biggest challenge that's kind of been shown in the literature and stuff, so.
Dr. Sciadini, how do you start this case? What's your order when you're doing a case like this?
I think for the residents in the room, for me, the most important first step is to get good contralateral fluoro shots and save them, because there's so much variability in the morphology and the position of the distal fibula in relation to the tibia that trying to judge your syndesmotic reduction, if you have a syndesmosis injury, without those films can be very difficult. And then, traditionally we start lateral, fix the lateral mal, and then go medial, but it really depends on the instability pattern, and frequently the medial mal, even if it's a small one like this, is the major contributor to instability, and if you start there and fix the medial mal first, it can make everything else a lot easier. And then lastly, if you have a posterior mal, which this doesn't, and you go to the lateral side first, it's nice to try to get provisional fixation with either just lag screws or a mini fragment type device that doesn't block your fluoroscopic imaging of the posterior malleolus, if you're going to fix the fibula first, and then you can go back to the fibula later and do more definitive fixation.
Yeah, and the fibula was a struggle here, and I did end up going to the medial side and trying to put that down. Again, it's a small one. I showed this case a few months back, and Susan's in the audience and pointed out that the medial mal is a little off, and it's a tricky one, even getting 2 screws in that. There's not a lot of room. I'd like it to line up better, and probably would have helped the lateral side. But the syndesmotic reduction on that 1 month out non-weight bearing film, it's really hard to say. I mean, you kid yourself that it's fine, but where its position can be a problem. You got a big stiff screw in it, though. So a weight bearing film post-op, he was a lacrosse player, not really complaining about anything. Anything anybody sees in this one, some of the fibular malreduction or alignment issues have healed in with the bridge plating at least.
Is that little avulsion off the posterior? Was that
Yeah,
there at the
it's
beginning?
always been there. It's there later on. I didn't know what to make of that. I mean, tell us what you're worried about with that.
Oh, no, I just,
If you're worried about anything.
no, I think
You
it's,
see it, yeah.
yeah. And probably like you said, it adds to the fact that it probably would have needed syndesmotic fixation at the time
Yep.
of surgery.
So who on the panel takes their screws out routinely? Who never takes them out ever? So everybody's in between.
Yeah.
So Dr. Long, when do you take your screws out? When do you tell the patient their screws should come out?
Football lineman, high school, college. I don't trust them either. Usually I put 2 screws in, take them both out. That's a definite. Then I evaluate the patient, expectations, activity post-op. Most people, I just let the screw stay. If they're very, very young, if I've got a 17, 18-year-old person, the screw comes out. 30s above, I'll leave it in. Low demand person.
And when do you take them out? When you know you want to take it out, at what point after surgery do you take them out?
Well, I've been old school. I move them at 6 weeks and things, and if I'm going to take it out, I take it out at 12.
You get an x-ray the day before you take it out, make sure it's not broken, or?
Oh, yeah. And actually, I've learned how to get them out if it is broken. So there are techniques to remove them. But We always take a look, make sure you're not going to struggle and you're prepared for whatever you have.
Dr. Sciadini, who do you take out?
And I leave it up to the patients actually a little bit. I think the important thing is if you make a decision, if you're gonna be an always leaver, an always taker outer, if you're gonna be a syndesmotic screw lever inner, you need to explain to that patient up front and make sure they're aware of the fact that they may come in to your office or somebody else's at some point and see broken screws. And if they know that at the front end and that it's not a harbinger of doom, then it's a much easier conversation when it happens. If you haven't forewarned them, patients freak out when they see broken hardware, and it can triple the amount of time you have to spend explaining it to them if you haven't prepared them for that.
Dr. Illical,
Yeah.
are there any patient reasons, complaints that they give you that say, oh, we can take your screw out and make that better?
Yeah, no, so I echo Dr. Sciadini's comment. So I'm very clear with the patients at the very beginning that I say if I'm going to put syndesmotic fixation, especially a screw, that screw is there holding your syndesmosis reduced, and that syndesmosis has motion. So in the future, when you start weight bearing, it may break, and if it breaks and doesn't cause you problems, then it's not an issue, and I don't take it out. But if it breaks and there's issues and you have pain things, then there's a possibility that we can take it out. But again, I think this goes back down to syndesmotic reduction and our inability to necessarily evaluate it properly all the time intraoperatively. So
Yeah,
I try to get as much information.
We'll talk about that. I do think that patients who feel a restriction of motion, especially dorsiflexion, that can be blocked by the syndesmosis being fixed by the screw. So specific elements of stiffness, I think I talked to them about taking it out more, and pain. Pain at syndesmosis, I do think, if it's rigidly fixed, can be helped with removal of the screw. And can they break in a bad way? That's a problem. Anybody seen, I've seen a segmental break of a screw.
Yeah.
I've seen it break where it's far in the tibia where it's broken, but it's not really let it loosen up at all. And I heard somebody describe this and do it to this day. I drill all four, so I drill through the medial cortex. I put it in 3, nice and long, and you can find that hole on the medial side if ever you need to come back and get the broken screw fragment out from the medial side. So he was not having problems, but showed up 5 or 6 months later, had broken the screw, and the little bit of syndesmosis malreduction resolved. And I think if you look at the first post-op weight bearing, he's got a little malreduction posteriorly, and then the screw breaks and it kind of settles down. There's actually literature that supports this, that when the syndesmotic screws are holding things a little bit malreduced at the incisura, the syndesmosis, that actually breakage can see that resolve, and certainly screw removal can as well. So just briefly, I quizzed a resident once on how many ways you can fix the syndesmosis, and you get over 10, and it's all these things, and now you have to add fixation of the posterior malleolus directly to that as well. But all we've talked about, the old absorbable screws, there are screw and wire techniques in the fibula and the tibia that you do a figure of 8. Direct suture repair has been described, suture anchors, soft tissue grafts. And this is a picture of something. I talked to Dr. Coetzee about this, and after they'd done suture buttons and assumed he was doing all suture buttons, and he said, yeah, some of them I don't trust, so I also put a screw in, which I'm not sure I get, but hybrid. Reduction is difficult to judge, and this is Dr. Sciadini's point about the opposite side or a normal beforehand. It's in the posterior half to posterior third. It needs to be a perfect lateral x-ray to assess it. And those are tricky to get sometimes, especially in the office. Malreduction's a problem. The group at HSS described this. It's 20 to 40% of times on post-op CTs if you're getting those. Don't get them if you're worried about it, or get them because you want to find it. This is the idea. So the vector and this is a hand drawing, so it's a deep incisura. Some of them are flat, but that round fibula to fit into the concavity of the tibia, a little bit of direction of a rigid clamp or screw will pull it, and a lot of biomechanics that let that malreduce. And then the 2 suture buttons to sort of sink it in but not be too rigid was the idea. This is the Coetzee article, and it allows that physiologic fibular motion, proximal translation, and a little external rotation as you move the ankle. Problems with suture buttons, they can separate over time. Painful osteolysis, I personally had to take out 5 because I put it in because I didn't have to take it out, and then the knot irritated them, or there was some problem where I had to take it out. They can get infected. The cost issue is really dependent on when you compare it to screws, if you're taking the screws out, because the cost of screw removal trumps the cost of the implant, but alone a suture button is more expensive than the screw, obviously. Hardware removal we talked about. There are many studies that say it's certainly not necessary to take the screws out. If ever that's a word, you don't have to take them out. It's well established in the literature. All right, now move on to another case. This is from Bill, so I guess you don't get any questions on this one, Dr. Long.
Okay.
But this is a construction worker, ankle pain after a bar fight. He's on Plavix, and he has intact skin. And these are his images. Dr. Illical, why don't you?
Yeah, so the 2 images of the right ankle show a complex right posterolateral ankle fracture dislocation with a comminuted Weber C distal fibular fracture. It's hard to say on that, but it's probably, it seems to be like a posterior malleolus fracture that probably involves the posterior medial aspect of the distal plafond as well. So obviously try to get it reduced and then post-op imaging.
Dr. DeLong, anything to add?
No, the spice of life here is the Plavix and the stents. This was a sick guy that used alcohol regularly.
And the X-ray on the left is a good AP of the talus and lateral of the distal tibia. So if we think we don't have a look at that posterior malleus, you have at least a sense of it through that, through the ankle on the left, which is the AP of the ankle, but a lateral of the tibia. Looks like the medial malleus intact. And we're to a question again. So this is about posterior malleolus fractures. So in the room, do you never or rarely get a CT? Just get an X-ray that gives you a sense of the problem. If it's big, I just made 10% my number. So get a CT if it looks like it's a big fragment, or get it if it's really big. I'm sorry, small, big, or really big, like 10% or really big. I guess the other question would be if you always get a CT if there's a posterior malleus. What does the panel say? Dr. Sciadini.
I think it's impossible to know until you have the CT, right? You can't tell the size of those posterior malleus fragments very reliably unless you just serendipitously get the exact right oblique to shoot down the fracture line. So if they have a fracture dislocation of any kind or an identified posterior malleus on the injury films, I get a CT scan. Because it's going to determine not just if I'm going to fix the posterior malleus, but what approach I'm going to take for it. I like to go posterior-medial when I can so that I can sort of do everything supine easily and avoid prone and posterolateral approaches to the posterior malleus whenever I can. So if it extends over medially enough, that's a good option.
I totally agree. I have the same CT indications, any posterior malleus and every fracture dislocation for the same reasons.
Everyone, Bill? Every CT on every posterior malleus?
No, not always. The fragment looks big enough. If I could reduce it, it looks okay reduced. Sometimes I skip the CT. It's not the expense or really the exposure. It's just that if I think I could do it without including that, I'll do it.
And it can be the ease. These will often show up in the office, and you have, if they're in the ER, you have access in the hospital. I'd get it if there's easy access to one. It can be tricky in the office to get them into the CT, back to the OR, all that stuff. And this is interesting. It just occurred to me because there's some discussion on this, and there was a review of posterior malleus in management, and there was a dichotomy between foot and ankle fellowship trained and trauma fellowship trained, like the whole table here, and the CT was one of the issues. So his pre-op films again, and we have splint films. So Dr. Illical, what are you doing for this now that you see it reduced, and the size of it being what it is.
Yeah, so, yeah, it's well reduced. I'm still concerned that
There is no CT,
Okay, so,
just to let you know.
okay. I still think that posterior is kind of posterior medial. I think it's sort of seen on that AP. So personally, I sort of like Dr. Shaffer, like if it's posterior medial enough, I like doing everything supine, so I can go posterior medial, fix that posterior fragment, and then fix the lateral side with the lateral approach. Or if it's, since there's no medial injury in there, I would go prone and just fix everything from the back.
And that's the big choice, right, is whether or not you have to go prone, how big it is, how easily you're going to be able to handle that.
Yeah. So in this case, since it doesn't look like there's any medial injury, I'd probably just go prone and fix the posterior mal and the distal fibula all from a posterior lateral.
You would put this one prone to start with. Dr. Sciadini?
I think that's a good point. When you don't have a medial injury to fix, then it becomes less of an issue to go prone. The only other issue with prone is, for me at least, imaging is always a goat rope. My brain can't process the patient in the prone position to be able to figure out how to get really good mortise and lateral views, at least as easily as I can supine.
Yeah. I have that because when they're prone, I think, their legs are externally rotated, so their approach is easy, but then getting, you either have to like fight to rotate it to neutral, or you have to get your x-ray to cant over, so, yeah.
Yeah, and anesthesia, it's just still, and it will always remain. And it is a risk. I mean, being prone is a risk for the patient, but makes you nervous. Bill, anything to add to what's been said?
No, that's, one of the things that intrigues me is that we have an O-arm in our OR now, and most of the time when I get into situations like this, I say to myself, maybe I should use that O-arm. Make sure I've got it where it is. It's very expensive to use.
O-arm is the intraop.
It's the intraoperative
CT.
CT scan, yeah. And it's wonderful to have, but a very expensive thing to use.
So, this is what was done. And I think, Bill, you said this wasn't your case, but was a posterior approach?
Yeah, it was posterior lateral approach, and it was done prone.
And true buttress, so no screws in the fragment, it looks like.
Yes.
Any discussion? Like it, don't like it?
No, yeah, I like it. Yeah, like I've tended to go with my posterior mals, especially when it's really distal, with like mini frag fixation that have like small tines, so that I can put that plate very, very distal and have the kind of tines act like the buttress, and then I don't necessarily put screws across that smaller fragments and just act as a true buttress.
And what it looks like in the office, and then down the road. I think that's what we have there. All right, here's another one. This is, I guess, kind of similar. 57-year-old woman, relatively healthy. She fell down some steps, initial AP, and this is a pretty good lateral in the office that shows that fracture pattern. It's just reminding we have fibula, medial mal, and that. CT, obviously, right? Right, yeah, not in this case. So here I'm asking, so this is a posterior mal that you know you want to fix. It's reasonably large, even on x-ray. It looks 20–25%. And when you're doing this, audience response, is it percutaneous front to back? Especially big ones, you can get the threads across it. Second is posterior to anterior, but you put them, just a hip on a bump like you normally do. Don't bother with prone. 3 is fully prone, plate on the back. And 4 is like full lateral, where you can work back there, but don't have to be prone. I thought this was a good question to ask. It may not be, but we'll see what people say. Anybody here do full lateral to try to get to these, or always prone?
It's prone is just much easier.
I really don't like prone.
Another
as a-
argument,
as a-
another argument I'd make for the CT scan is you identify if there's impaction and more of a sort of posterior pilon configuration of this, and that would influence me again to try, if possible, to go posterior medial, because you can actually see into the articulate, you can see the joint and reduce it through that, whereas prone and posterolateral, you're relying only on extra-articular keys. You can't really very easily address the impaction.
Sorry. So posterior, a lot of people front to back, and then some options. Yeah, the CT to localize the fragments, especially if there's a posteromedial component or impaction, because the posteromedial, you can get that approach from them supine and get good fixation and even better direction of fixation, because sometimes the fracture obliquity fits better in that direction. So this was reduced, and you can see that gap, see the articular surface step off. And this is one that I did, and did her lateral on a bump. It does make you fight a little bit more to get in the midline, which is why the plate is coming over the back. And I do the fibula and the tibia through the same incision, just sneak around the perineals. And we do 2 incisions, do 1 incision. Thoughts about that?
Yeah, if I'm going prone, and I fix everything from the back, I just do 1 incision. And usually I put my plate more posterior, unless I have done it with, like you, I've kind of snuck around the perineals and put the plate lateral, but try not to do that.
And then the medial mal, which we knew we wanted to fix on this. It's hard to do prone, maybe impossible to do prone, and I was able to rotate this leg, let the beanbag down so I could rotate her to do a more standard traditional medial mal approach. I did a pelvic recon just to be able to contour it here. You don't get that T configuration on the bottom. I did some interfragmentary compression screws, and it ended up pretty good. So I alluded to this earlier. They did a Foot and Ankle International article on surgeon practice for posterior mals, and it was basically a questionnaire as to what you do and why, and the most important factor to the poll was stability and, quote, other factors, which I took to be articular surface issues, either comminution step-off or marginal impaction. Size was secondary, and size was very variable in terms of what people thought, must or must not be fixed. It was 95% said you needed to fix. I think a 40%, so not everybody said 40% or more. And at 10%, it was 10% of the back of the joint. So 10% involvement of the posterior was something like 20% of the respondents. I think I'm off my numbers, but it was interesting to see what sizes people thought needed to fix and some that they didn't think. And there was a difference among foot and ankle, fellowship trained and trauma trained, both in how you fix it and then the direction or the method of approach, with the trauma surgeons going almost routinely in the back and with plate fixation and vice versa. The syndesmosis can be rendered stable after fixing the posterior malleolus. There was no need for syndesmotic screws in either of the previous cases. Again, the PITFL intact, attached to that fragment. You put that down and hold it rigidly. It renders the syndesmosis stable. This was a study that showed that. This was all with prone positioning, and they argued for that as a way to deal with the syndesmosis. I found this, and the posterior mal and syndesmosis has been a little bit hot recently. Dr. White out of Edinburgh, Scotland, said, we don't have actual outcome studies on this. There may be some issues with routine posterior approaches that could be problematic, maybe some increased HO or some other issues that we should have better studies weighing the risks and benefits to know for sure. So there's not really a scientific response, but at least an opinion response. Anybody know Dr. White? And if you have an interest in the posterior approach that we've been discussing, there is a techniques article in the JBJS that you can find. It's referenced. So we have 8 minutes and one more. Sounds good? Yeah, this is, kind of a little bit of all these, somewhat interesting. 61-year-old woman fell down steps, closed direction in the ER, and these are her injury films. And just to go through this a little bit, obviously fracture dislocation. She has a posterior mal and lateral side, a closed reduction, and then in the office, splinted, she's got that. And you can barely see it through all of the splint material, but so thoughts, anybody? Dr. DeLong, what do you see here?
There's a large fragment there that should be significant to the stability of this ankle. And, it's probably going to be very important for providing stability and restoration.
Even the non-fellowshipped orthopedic trauma trained gets a CT on this.
Yep.
And there it is. Where did that piece come from, Dr. Illical?
It looks like it came from the posterior plafond.
How, it's in the front of her ankle.
Yeah, well, I mean, she was dislocated, right? So probably squirted out the front during the reduction.
Couple
Front of
more
her ankle used to
views.
be in the back of
Yeah.
her ankle.
That one, that one, there's the hole it came from.
It's a bucket handle fracture.
Yes. So, had a lot to do for her and ended up getting it out from the lateral incision and then putting it in the back and holding it in and putting more screws than I usually like to use, but less than you do, Dr. Illical, so. Medial malleolus here. So she had some comminution on the medial side, I think. And as we were saying, with the posterior malleolar fractures, you can get a sense of their orientation, and she's almost straight coronal there, maybe a little bit more lateral with that impacted piece out. But a fair amount of articular surface damage. I did stabilize her syndesmosis and used a screw outside the plate and some follow-up. And I did take her screw out, syndesmotic screw out eventually for stiffness and pain issues. So just, this was an excuse to run through some medial malleolus stuff. There's a real nice review article with some great references from the British Bone and Joint Journal from this year, just a month ago. Current treatment conferences had some interesting take-home points we can get maybe some panel discussion on. Isolated medial malleolus fractures, nothing else. They're rare, but how often do you fix those? How often do you leave them alone, treatment, a cast? Dr. Sciadini, isolated medial mal.
I used to be a lot more aggressive about them than I am now. In my training, I was told, oh, you have to fix them because it's an articular injury, it's bathed in synovial fluid, and they don't heal. And I think the literature does not bear that out and shows that they can be very routinely treated non-operatively. The exception is if there's impaction up in the shoulder and over, extending onto the weight-bearing portion of the plafond, then that by itself buys of an operation.
Yeah, and this had literature talking about displacement, and I think this means that if there's displacement, there's really a risk that there's some soft tissue in the fracture site. That increases your risk of non-union there. But with less than 2 millimeters displacement, the non-union rate is quite low, and these can be safely treated close and equivalent outcomes and results. In a well-reduced medial malleolus fracture, so well-reduced medial side, in a bi or even trimal, there's literature that says they can be left alone. Non-unions are not common, even if present are often well tolerated. We've all seen this, but probably not done it routinely, like just leave it alone if you know it's well-reduced. Anybody?
Yeah. I've only done that in patients with poor soft tissue envelope medially and have multiple medical comorbidities that I didn't want more soft tissue complications, so I've left that and they've tolerated it, but it's like you said, few and far between.
Yeah, but certainly an option, especially for those circumstances. There is good literature on just a single screw on the medial side being enough. There's not a lot of room there. The soft tissues around there are prone to injury or iatrogenic problems, and putting 2 screws routinely is not necessary. There's literature support for a single screw. Soft tissue injuries I just talked about. For pain over the medial side, hardware removal is not benign. If they're painful from the screw head, if it's sticking out, pretty sure, but it's hard to know what the pain is coming from. And in the studies that they quoted, there are people that still had pain afterwards. The scar tissue you create when you take it out, it's obviously a frank discussion with the patients when you're doing that. And this last one, I think this is really neat. I haven't done this as much, but we'll try to add it more. For that soft osteopenic bone, grabbing the far cortex, getting a little bit more compression, is good literature support for improved fixation and stability with that. Anybody here routinely do that? Think about that?
Yep.
You need to get the long screws out, I suppose.
Yep.
Good. We're good. Thank you, everybody.